All right, so these are our disclosures, and including that both Dr. Snyder and I are consultants for Monteris. So essentially, this presentation is to talk about sort of where we started and where we are now and how we got there. And we do quite a few laser ablations here at Henry Ford now, including we use both platforms, but certainly I think there is a strong role for where Monteris fits into our treatment paradigm. And hopefully what we can go through today is basically, some of the growing pains that we went through. And hopefully in that way, we can help other people avoid having to go through those growing pains and sort of, I'm not sure, is it steepen or make it less steep, the learning curve. I think you want to make the learning curve more steep, actually, is to make it faster. I think is how it works. And actually, this is a nice slide. Actually, it's a position statement that was just recently put out by the tumor section from the CNS and AANS, which supports the role of laser ablation in various neoplastic conditions, including for recurrent glioblastoma, recurrent metastases, or other tumors that are deep-seated tumors that are otherwise difficult to access or too dangerous to access through open means. In particular, there's also a strong role for LITT in treating radiation necrosis, and I'll get to that later on in the presentation. And in essence, you can achieve a lot of the benefits of an open surgery through less invasive means, and such that even in some of the larger other societies, like for instance through the NCCN, there actually is their guidelines were also revised recently to incorporate LITT into the treatment paradigm, and Dr. Snyder will speak on that. So I think when you're getting a program started, this laser ablation does not exist in isolation with just neurosurgery. It really does depend very strongly on the team approach to it, because at least for us at Henry Ford, it was the neurosurgeons, the neuro-oncologists, radiation oncologists also had a large role to play. Even though they're not directly involved in the treatment, they are definitely involved in sort of where does their treatment sort of fit in, before or after LITT or instead of LITT. The medical oncologists, also radiology, because certainly we're very heavily dependent upon MRI. And even at a place like at Henry Ford where we have an intraoperative MRI, it does require a very, very close collaboration with the radiologists and the techs to really get this program off the ground. And it also requires this constant feedback loop. It's we're fortunate here at Henry Ford that we have, or at least I'm fortunate here at Henry Ford that I have neuro-oncologists that are surgically minded. And so they see the value of cytoreductive procedures, including laser ablation. And in fact, over time, in the last 9 years, what we're seeing is that, as we see our successes with laser ablation, we get a better and better sense of where we can take this in the future. So at Henry Ford, we do have a tumor board that meets on a weekly basis. And basically, it ends up being about 30 or so people in the room, encompassing all the different disciplines that touch these brain tumor patients. And LITT historically has not really been part of clinical trials. And so in large part, up to this point, most of the patients treated with LITT were not trial candidates, but I think that's something that's also that's changing now. And I would expect that LITT will become more and more a part of the clinical trial protocols in the future. And it does take a village to get the program off the ground. This is a meeting that we had prior to one of our first ablations, and basically showing the various representatives from all the different teams. There's neurosurgery, neuro-oncology, radiation oncology. There's also our OR support. This is our head nurse. And actually, I wanted to give a particular shout out to Lisa Scarpace over here, who actually is, I think, depending on what day of the week, she's either my work wife or my work boss. Basically tells me where to go and what to do, and really is how we're able to get all this stuff done, and is really truly the unsung hero behind our brain tumor program. When we're talking about prospectively, talking about stereotactic biopsy versus craniotomy for a patient, either to the patient or in the setting of a tumor board, these are the factors that we're looking at. The benefits of a craniotomy, you get a lot of tissue, generally speaking, so it limits the issue of tissue sampling, where the sample you get is not representative of the whole. you get immediate cytoreductive benefit, and then along with that, you get immediate relief of mass effect. Of course, we also know the downsides of that is that it's certainly an invasive procedure. Even when it goes well, you're still looking at significant recovery time. And generally speaking, a length of stay that's usually in the range of 3 to 4 days if everything goes well. Certainly with COVID, we were pushing to get patients out earlier, and we've been sort of pushing the envelope as far as how fast we can get patients out. But generally speaking, you're still looking at a significant length of stay. In contrast, with stereotactic biopsy, it's a less invasive procedure, overnight stay. You get tissue, but not as much tissue as you get with a craniotomy. So there's the issue of sampling error. You also don't get any relief of mass effect and no cytoreduction. So with laser ablation, it kind of threads that needle in between a craniotomy and a stereotactic biopsy in terms of benefits, pros and cons. The main thing is that with laser ablation, you get immediate cytoreduction of the mass, which you don't get with a stereotactic biopsy. The downside to it is that with a laser ablation, you generally will get an increase in the mass effect, both due to an increase in the size of the ablation zone, which typically, at least in our experience, will roughly double in volume over the next 24 to 48 hours. And then there's also a concomitant increase in the vasogenic edema surrounding the ablation zone. So if mass effect is a problem on presentation, it will become worse after a laser ablation. And so if you're trying to evaluate a patient for that, that certainly comes into play. So back in 2013, when we were looking at our first cases, these are some of the comments that that were going around the room. It's not going to work. Why would I do this? Why would I buzz it with a laser? Take 4 hours to do that when I could just take it out with a cranial, go a lot faster. It's too expensive. The disposables are 15 grand a piece for one laser fiber, and so that's going to eat up all of our profit, and then also cannibalize our craniotomy volume, and we're going to end up losing money on this. It's going to take too long, and I mean, our first cases did take a long time, and honestly, it seemed kind of gimmicky. So, and those are all comments that came from me. So, so through kind of gritted teeth, we did our first several cases. This is kind of what was going through my mind when Monteris came in to give their presentation. This is back in the day when Monteris was still using the tripod system. I forget what it's called, but it was a tripod system to secure the laser fiber in place. And this is kind of what it looked like to me. Luckily, we've since moved away from that, and the bolt works a lot more nicely. And so at this point, it's really the indications for it for our services. Recurrent metastases is a strong indication. Primary brain tumors, radiation necrosis, epilepsy although I don't treat epilepsy patients. And again, with the Monteris system, you can typically create a lesion about 2.5 centimeters in diameter, but along with that, you tend to get worse swelling, and then actually will make mass effect worse. So when we're trying to start this program up, basically we're like, let's start with the easy cases, and then try to start with cases that will prove the value of it, so that we don't sort of cut off the program at its infancy when we're just trying to get things going. Like the worst way to get started off is to immediately start off with the hardest cases, and then really, even though you might think that you start with the hopeless cases because it's you really have nothing else to offer them, those are the high risk cases as well, and not the ones you generally would want to start with. So with that in mind, you want to avoid larger lesions that have a lot of mass effect or edema. And then also potentially there are cases where you're worried about the combination of treatments. We did, in our early experience, have some issues with patients who had laser ablations and radiation treatment in close succession. And some of those patients had really malignant cerebral edema. Although I think as time has gone along, that concern has kind of dissipated. So in addition, when you're looking at your first cases, I think, especially with the Monteris system, this sort of yellow line kill versus blue line is very important. So generally speaking, if you're talking about ablation, so the blue line kill, or 43 degrees for 10 minutes, that is cell death. And the yellow line, 43 degrees at 2 minutes, that does not mean permanent cell damage, but certainly that can cause transient issues. And so if you're treating a lesion that's close to eloquent tissues, especially if you're first starting off, this is a place where you probably want to be more conservative, where you don't treat the blue line all the way up to the edge, where the yellow line is going to cross over into those eloquent tissues. And instead, you might choose to say, I'm going to stop when the yellow line hits the, hits the eloquent side. For instance, like I was treating a patient recently with a pilocytic astrocytoma in the temporal lobe who did not have a visual field deficit and definitely wanted to avoid that visual field deficit. So I did somewhat undertreat that lateral side where the optic radiations were passing because I did not want to cause any transient visual issues. So in terms of some of our early cases, this is a patient who had a recurrent glioblastoma. I think actually this was quite a compelling example of what we could do with a laser ablation. You can tell that he has a prior resection cavity, and the patient got through that surgery just fine, but had a focal recurrence here in the mesial temporal lobe. And we did an ablation of it, and it was really quite striking the way that the ablation conformed to the ambient cistern and did not injure the brainstem. And so that really, provided a lot of enthusiasm early on from the neuro-oncologist because they also saw how quickly he recovered from the surgery. This is actually one of our really striking early success stories. This is a patient who had metastatic melanoma who had an area of focal recurrence, recurrent enhancement about 18 months after radiosurgery. And so in that time period, it's kind of getting out of the window for where you think it's going to be radiation necrosis, and you could be very well dealing with recurrent tumor. And so in that case, if you just said, well, it's 18 months, maybe it's just recurrent tumor, would be radiated again. Our radiation oncologists were not really comfortable doing that, and they wanted tissue. And, this is on the surface. This is something that you could certainly easily access with an open craniotomy. But when we talked to the patient and we thought, this might be a good case for laser. It's small, it's right on the surface. It's, close-ish to the speech area, but he didn't have any deficits. And so we decided to give it a try, and, it really worked out quite well. These are the post-LITT changes that we saw 2 weeks. And then, subsequently this ablation zone over the course of a year really started to come down until now. It's actually, we're 8 years out now, and he still has not had any recurrence. And this is a patient with metastatic melanoma to the brain. Typically their expected survival is usually less than a year. And then this was another one of our really early success stories that really provided a lot of that early enthusiasm for for laser ablation, where we treated a patient with a recurrent glioblastoma that was just anterior to the motor strip. And what you can see here is that the laser ablation, the ablation zone actually conformed nicely to this precentral sulcus and did not injure the corticospinal tract. And so this patient came out with no deficits. He actually had a pretty bad deficit after his first operation because you can see that the resection actually happened in the motor strip. And so he was very happy to avoid another round of hemiparesis. But along with our successes, we also had some early disasters. So, with those early cases, we sort of got maybe a little bit over a year with the technology. And so these are some of our cases that went really, really badly. This is a patient who had a cerebellar anaplastic astrocytoma. And when I did her ablation, the ablation looks good, but I think I also damaged the dentate nucleus while we were doing that. And she ended up with severe truncal ataxia that never really got better and really actually inhibited her ability to tolerate any further treatment. And, so ultimately she did pass away because of recurrence of tumor, all the while being very, very unhappy at her neurological condition, which, she was basically, her quality of life had been ruined. And before the procedure, she was normal. The patient in the upper right was a patient with a newly diagnosed glioblastoma. She was quite frail on presentation. And, we got a good ablation, and she wasn't even that bad off neurologically, but just it was too much of a hit to her. She got a spastic hemiparesis, still very much anti-gravity, but, she never really got over the ablation, wasn't able to get adjuvant treatment, and ultimately passed away soon thereafter. And the patient on the bottom left, this actually perhaps is not so much a problem with the ablation, but with the biopsy. This patient is who had a newly diagnosed breast met. And when we did the ablation, or when I did biopsy, I probably seeded the tract with tumor and caused leptomeningeal dissemination that happened within 6 weeks of the ablation. And then finally, in the patient in the bottom right, we were treating a patient with recurrent meningioma. The ablation actually went quite well, where we got a gross total ablation of the contrast enhancing mass. But what happened subsequently is the patient got terrible cerebral edema afterwards and ended up almost completely hemiplegic on the left side, which didn't resolve for about 6 to 8 months. Ultimately, she did come back almost to normal, but having to see her day after day, each day getting worse with worsening hemiparesis, was not happy. She wasn't happy and I wasn't happy. Although subsequently she did get better. So with our adoption, a lot of you have probably seen this board. This is the sort of the adoption curve. And so from our first case in November of 2013, we did our first 3 cases, got really excited about it, and then we were doing really a lot of cases with it. And then, with some of those bad outcomes, then we kind of pulled back for a bit. And gradually over time, we've sort of increased our, come to more of a steady state as to what we're willing to treat with laser ablation. And I think actually the reason I make this comment over here about, 2 surgeons is like one of my partners actually has really gotten into laser ablation as well. And the reason I mention is that when he first started with us, he actually trained here, but when he first started back on staff with us, and we were sort of talking about, whether or not he was going to do laser ablations, he was kind of like, I don't know. I don't really believe in it. I don't think it really has a role for my practice, meaning him. But, if anything, I'd say that he's actually even more aggressive with laser ablation than I am these days. And so at this point, we're probably doing, I'd say, strong, at least 3 to 4 cases a month. Sometimes it's even more. And, I think this sort of expansion of the technology, acceptance of the technology, not only to my partner who does laser ablations, but within the group, even though they may not do laser ablations, they see the value of it and will send those patients either to myself or Adam to treat those patients. I think it really does provide a compelling value proposition for the patients. And, I think it's really, when you see these patients afterwards and see how well they do, it's really quite an easy sell now. So over time, what we've seen is that we really have gotten quite aggressive with laser ablation once again. These are some of the recent cases that we've done that, went well, but we're, I'd say that, are definitely pushing the envelope for ablations. Like this is a patient who had an aggressive pilocytic astrocytoma within the midbrain. It is a subtotal ablation. It's quite big. And I guess the plan initially was to allow it to collapse down and maybe try again after it collapsed down. But the nice thing about it is that we were able to cytoreduce this tumor that was sitting within the thalamus and midbrain and not hurt him, and allow him to go back onto treatment. He was treated with Avastin subsequently. The patient in the upper right is an insular oligodendroglioma. This is a patient who I'd been sitting on for quite a while before I decided to treat him. He was, he had had a biopsy quite a few years in the past and just had this tumor that was slowly creeping along. And while I was doing laser ablations on other tumors, I wasn't quite ready to tackle an insular tumor, in part because I was afraid of causing a stroke. There are the traversing M3 perforators that go through the insula that supply to the corticospinal tract, the cortical radiata, and I was worried that if we ablated it, that we would cause a stroke. And finally, I bit the bullet and decided to treat it, and he actually did quite well after this ablation without any additional neurological deficits. The patient on the bottom left, I don't think this image really fully portrays like how large that tumor was. This is actually a case where I did 2 ablations that were very large, and the total volume was about 30 cubic centimeters. And then subsequently did an immediate debulking afterwards, a planned immediate debulking based on some of the experience of the guys over at Cleveland, the Cleveland Clinic, and she did quite well with the procedure. And even though we did 2 operations, the second operation was a lot less invasive than what she probably would have undergone with a true open resection. And then finally, this patient on the bottom right, that's I think another striking example of a patient with a thalamic cavernoma who is the sister of an MRI tech here and also an ultrasound tech herself, and came in with a bleeder in the thalamus, and ultimately she had a history of prior pilocytic astrocytoma, so this is probably a radiation-induced cavernoma, and she was really done extremely well after the ablation and this area has regressed even further since then, and she is now able to work full-time and take care of her kids, and very happy. So, and I think actually this is another case. This is not a case I would have tried to do back in 2013, but this is a patient who has a low-grade astrocytoma, which is largely within the anterior perforated substance. And so this is another patient who I would not really regard as an open resection candidate because of the risk, because of the almost unavoidable risk of stroke, because of the perforators that go through the anterior perforated substance to the basal ganglia. I showed this case around. I showed the MRI around to some of my laser ablation colleagues around the country, and I said, what do you think? Should I try it? what will happen? Will he get a stroke? And the answer was like, well, probably not. And so after much discussion with the patient, we did try it, and we were able to get a really nice cytoreduction on the tumor, basically almost an entirely a gross total ablation of the mass, while not causing any additional neurological deficits. He was neurologically intact and he came out intact. And this turned out to be a grade 2 astrocytoma. Given the lack of measurable disease, he's actually just been in imaging surveillance since then for the last year and a half, and doing well. Basically, what we're seeing is that the ablation zone is gradually decreased over time without any signs of recurrence. So looking back at some of these early cases, it's not that I think that these were mistakes of execution. I think these were largely, some of these, if I tackled these cases today, the same problems could have happened. But with the experience that we have garnered over the last 9 years with, almost 200 cases, I think it's sort of, there is no risk-free procedure. And even if you do have a bad outcome, you can sort of say, you can see the forest for the trees and accept sort of the occasional bad outcome for the overall good outcomes that many more patients will have. Some of it is patient selection. Like I think this patient, this is not a patient I should have done an ablation on. It was just too risky for injury to the dentate nucleus. This patient over here, this is another patient where I probably should just have not done an ablation. It's just too much ablation, too deep, too much edema for a frail patient to be able to withstand. This is a patient, this one on the left where I seated with the biopsy. It's not an ablation problem, it was a biopsy problem. And even today, if I were to treat it, perhaps I wouldn't have tried an ablation. It's too big for that. But in her case, it wasn't an ablation problem. It was a biopsy problem. And then finally, this patient on the bottom right, I think again, the ablation wasn't that big, and I still don't really know why she got such bad cerebral edema afterwards. Knowing that, I mean, I sort of shied away from ablating meningiomas, although Dr. Snyder will show a case where I did one anyway. But ultimately, actually, although I say it was an early disaster, it's actually a late success because she's actually been in long-term imaging follow-up. She's about 7 years out now from the ablation without any signs of recurrence, and also back at work full time at this point and essentially neurologically intact. So I think when you're evaluating a patient, who's a good candidate for a laser ablation? Well, those patients who, kind of fail the eyeball test for an open resection. Frail patients, particularly patients with recurrent glioblastomas, they don't have the same kind of reserve as when they're first diagnosed. And also, to be frank, a cytoreductive procedure, whether it's open surgery or laser ablation, you're not talking about hitting a home run here. It's, you're talking about maybe a single or a double. And so you don't want to put them through a big procedure for something that frankly does not provide that much benefit. And so if you can get them in and out of the hospital quickly, I think that benefits the patient, gets them back on adjuvant treatment quickly. If you're treating a small tumor, but in a bad location where you can't do a supramaximal resection, that's a good candidate for laser ablation. If there's a wound that, if the patient's scalp is kind of exhausted from multiple treatments, surgery, radiation, that is probably a good one for an ablation since you're not talking about a big incision. Certainly in this day and age with limited resources and also in COVID times, laser ablation has actually become a bigger part of our treatment paradigm because we are able to get patients out of the hospital so quickly and they don't go to the ICU. It's almost an outpatient procedure at this point. And so when I'm talking to patients about laser ablation versus the alternative procedures, part of the discussion, which I think Jim will also talk about, is, we still do a biopsy, although it can interfere with the ablation, with the visualization of the ablation. I think there is still a role for getting tissue. Certainly the oncologist will want tissue, especially in the setting of recurrent metastatic disease. I think it is very valuable still. It does give you the opportunity to basically run molecular testing again and perhaps come up with better adjuvant treatments after the procedure. I think it's also, you definitely want to do it within the context of a multidisciplinary tumor board. You don't want to be the cowboy out there doing laser ablations on your own and then, sort of just shifting them off to the next person. You want this treatment to exist within a multidisciplinary tumor board where, it sort of fits within the treatment paradigm and not existing outside of it. And I think with that, I'll stop there. Are there any
So,
questions?
Dr. Lee, maybe
Yeah.
just one quick question is before we turn this over to neuro-oncology.
Yeah.
How do you think about steroids post-procedurally for your patients, and kind of what goes into the decision
Yeah.
as to the strength and the course? And if you just talk about that for a second, that'd be great.
Yeah, so I think as time has gone along, I've gotten more aggressive with weaning of steroids. It used to be when we were first starting it, because of some of the reports of malignant cerebral edema that would persist for months. Our paradigm at first was to put them on 4 milligrams every 6 hours, and to do that for 2 weeks without any weaning, and then get another MRI, and then start weaning after that. And what that ended up meaning was that those patients were ended up on steroids for roughly about 6 weeks if we were able to wean them off steroids. And the patients hate that. It's funny that the craniotomy patients don't seem to be bothered so much by it, but I think the craniotomy patients, especially the newly diagnosed GBM patients, they don't notice it as much because they're going through so many other treatments at the same time, like radiation. But for the laser ablation patients, like that is the most common complaint I get from them is the steroids. And so what we've done over time is we really tried to get very aggressive with weaning steroids. So if it's in a location that is not particularly eloquent and it's a small ablation, let's say 5 cc's or less, then I'm going to try to get them off within a week. I know other places are even more aggressive about it, where they're doing steroids for just 24 hours. If it's a tumor that, if it's an ablation that's relatively large, like in the teens in terms of volume, like 15 cubic centimeters or so, or if it's close to eloquent tissues like the cortical spinal tract, then I will do a slower wean. I don't think there's any real magic to that, but still, even in those patients, I'm going to try to get them weaned off within 2 to 3 weeks.
Super. And then as we shift to Dr. Snyder, maybe you could spend 1 second, Dr. Lee. If you were talking to medical oncology about how LITT might fit in the context of their patients, is there anything based on this, the slides you've shown us thus far, is there anything in particular that you would reinforce?
Yeah, I think the patient. So the fact that the patients are living longer these days with cancer, it also means that the patients are living longer to have recurrent disease. And in the past, with metastatic disease, like most of those patients were dead within a year, and so they didn't really live long enough to have the side effects of radiation. And so I think it's these days we're seeing more and more patients have either recurrence of disease, of brain metastatic disease, or the treatment effect. And we've seen it as far as more than 2 years out from the radiation treatment, where you think, oh, it's got to be recurrent tumor. We've actually seen cases where more than 2 years out, we're still treating with it's still a radiation necrosis or treatment effect. And so I think it is really quite, there is a school of thought where you say, well, it's got to be tumor, we're going to treat it with radiation again. And I think, this really does provide an opportunity for if you're treating radiation necrosis, this treatment can be largely curative. And is actually, there's data that Dr. Fetchy put out through the Lantern group, where you actually do a better job of weaning them off steroids if you do LITT than if you do best medical treatment, so steroids and Avastin. You're actually more successful in getting them off steroids with laser ablation. The ability to get tissue is also important, although laser ablation for recurrent metastatic disease, there's a very high rate of recurrence. Knowing that you have that recurrence and possibly doing repeat radiosurgery after the biopsy, knowing that it's recurrent disease, I think gives you a chance to treat it earlier on before it has a chance to recur further after the ablation.
Great, thank you.
Yep. Okay, so I'm going to shift it now over to Dr. Snyder, and I'll hang around to the end for any questions.
Well, thanks, Ian. It's exciting to see where you started and where you've come from technically with laser ablation and our approach. And to add to that last question, I think it's really valuable to have alternatives to steroids in this day and age of just rapidly advancing immunotherapy treatments, particularly for metastatic disease, because you don't want to have somebody on long-term steroids for radiation necrosis or other inflammation in the brain that limits the efficacy of their systemic disease treatment. And so if you can offer laser ablation and expedite that return to getting somebody off steroids, that certainly has an advantage. Well, I wanted to share a few of my favorite laser ablation cases, and then definitely share my own perspective. So this is a gentleman with a grade 3 meningioma, and he had exhausted radiation. This was his 5th surgery fifth of 7, I believe, and had been dealing with this malignant meningioma for years, had been on Avastin in clinical trials, and he had very poor overlying skin integrity. So what Dr. Lee was able to do was ablate this focus. You can see the laser ablation catheter here, and this is after the procedure. He was able to ablate this focus. And I know it was not one of Dr. Lee mentioned is not one of his favorite types of cases to treat was meningioma, but afterwards the patient said to me, can I just have a laser ablation every 2 months instead of doing chemotherapy or radiation? So the patient was really satisfied despite Dr. Lee's opinion about the case. This is another case that seemed valuable. This patient was a concert performer with CNS metastatic disease. Here, this was treated. This is actually the post-treatment nadir scan after radiosurgery. And then over time, that was showing some changes and affecting her ability to perform in the concert band. And so Dr. Lee was able to take a biopsy of this tissue and ablate this focus, and it ended up being treatment-related changes. So she didn't have to go on further therapy or have additional treatment to this focus, and improve functionally and return to her way of life that she so enjoyed. And of course, these are some of my big win cases that really inspired me to take a deep dive into laser ablation. This is another interesting case of an oligodendroglioma patient in his 30s or 40s who had been dealing with an oligodendroglioma for about 12 years. And at that point, he started to have this T2 change here adjacent to that resection cavity. And this patient has always followed his own path. And what he wanted to do was something atypical. He didn't want to do chemotherapy or anything like that at this time. And so Dr. Lee was able to do an ablation and ablate that focus, which did show recurrent oligodendroglioma and actually escalated in grade to a grade 3. The patient declined any further treatment, and it's been now 2 or 3 years, and this has been stable. So he's done quite well with this approach. And as Dr. Lee pointed out, some cases to avoid when starting out would be deep thalamic tumors or large tumors where the patient where it's just a large target technically to approach, or where additional edema may be an issue for a patient, a case such as this. This is another case that I think is just really fascinating and a clear example of where the team is going with laser ablation, or has gone. But this is definitely not where I would start out with laser ablation either, where this patient had a resection followed by 4 laser ablation catheters to a high-grade IDH mutant glioma. So really interesting, really attractive approach, but also complicated from a technical perspective, I'm sure, and also complicated from a imaging navigation perspective afterwards. So you want to get buy-in with your team right out of the gate, and this is really interesting, but may not be the approach to take. So when I'm presenting laser ablation to patients, my patients always gravitate to reduced time in the hospital and health-related quality of life benefits. They love it. Almost, especially recurrent patients that have had an open resection, the idea of being in the hospital and going home the next day and returning back to their own home is really attractive. They also are fans of a smaller or less invasive incision, and that's less disruptive to their lifestyle and perception of self. And if you're talking about recurrent glioma or recurrent brain metastatic disease, or even presenting initial brain or metastatic disease or primary brain tumors, time is precious, and so is quality of life, and that's always the focus. These are non-curable conditions, so we really have to take that into account. But I do always express the following concerns. The patients are often on a higher dose of steroids after the procedure than they may be on a debulking procedure. And that there's also can be sampling error with a biopsy. If you do a biopsy and it shows that it's treatment-related changes, and then you ablate the rest of that tissue, perhaps you just sampled a different area of that change than what shows the recurrent cancer or tumor. But then you don't have the opportunity to go back in and take another biopsy because you destroyed that tissue. Initially, we had issues with genetic testing from the small biopsy samples from the laser ablation, and that created some reservations with the medical and neuro-oncology team. But I just haven't seen that in the last several years, maybe 5 years. Perhaps that's from advancing sequencing technology, but I can't recall the last time that was an issue for us with laser ablation in particular. And I think we're really invested in clinical trials here, and you need to verify how laser ablation fit into clinical trial protocol. In the past, we had preferentially chosen laser ablation cases for patients that were not interested in clinical trials, lived too far away, or we didn't anticipate a clinical trial. But now clinical trials are much more open to having laser ablation be part of someone's care, and it doesn't seem to be the same limiting factor, but important thing to look into if you're navigating laser ablation for a patient. Something important to me is the critical review of advancing technologies such as laser ablation. So I think that's just as important on your first case as your 300th case. And it's important to monitor for safety, case selection, and outcome. It's important from a quality control perspective, an education perspective for your care team, and a communication perspective. So at our center, the nucleus of neuro-oncology care is tumor boards. We have 3 tumor boards: brain, spine, and brain metastatic disease. This spans 5 hospitals and serves as a prospective case management meeting. Most centers do have a tumor board. They may be run differently, but ours is a high volume tumor board where we're looking at all the cases in real time, each step of the way, so that we can guide that treatment and navigate the resources and landscape so that things happen according to our care pathways, which I'll touch on. So we're often using the neuro-oncology tumor boards as a discussion forum for laser ablation case selection, and it also gives us a chance to look at these cases longitudinally. At our center, most of our patients are with us from diagnosis to completing treatment or end of life. So we're seeing that long view of their experience, and the whole team is seeing that through tumor board, and that helps us navigate cases too. And I also think it's really important to engage with external stakeholders in discussion regarding laser ablation and these other evolving technologies. Chances are that if you're a center considering or using laser ablation, that you're probably a major referred to center in the region and providing this basket of care. So how does a patient get to laser ablation as a possible intervention? At our center, that's often through tumor board review. Of course, docs or care teams or nurse navigators will reach out to specific physicians or specific care pathways to get them in that system. But we run everything through a tumor board, and we spent years of very early morning meetings creating this cancer care pathway that are disease specific. So we have a specific pathway for primary brain tumors, metastatic tumors, and spine disease. So within the system, if a patient hits the ER door and there's a concern for a brain tumor, there's an ED/EHR referral into our tumor board that goes right to the group, and there's a process each step of the way to continue to review that case. So we'll review it before surgery, after surgery, with the pathology, any recurrence, and it plugs into this cancer care pathway, and that really lends well to navigating laser ablation cases. There's a lot of work to create these pathways, but it's created a return. So at our tumor board, we're talking about treatment, surgical interventions, clinical trial screening, coordination, case management across the health system, and we're not telling different providers to act in a certain way, but we're letting know the resources and making sure that clinical trial screening and access to things like laser ablation happen in a timely fashion. And increasingly, laser ablation has become part of our care pathways. This is a really beautiful schematic of care for brain metastatic disease that was recently published by our group in a textbook. And you can see this circled area is a blow up from right here. So specifically patients that have had radiation to the brain, we think there's recurrence. We don't know, is that recurrence or a treatment related change? That's a perfect patient for laser ablation as long as those technical parameters are met. And actually it feeds really well into some of our other clinical trials for brain metastatic disease. So we've had clinical trials looking at the radiomics of recurrent lesions after radiosurgery, as well as molecular driven trials where doing a biopsy of this recurrent disease and looking at that molecular profile, which is often divergent from the primary disease, can guide treatment and provide other treatment opportunities.
Dr. Snyder, one quick question. Could you just spend a second talking about how Avastin fits in your practice broadly?
Sure. So Avastin, we do use that as a line of therapy for glioblastoma, but I presume this question is more so about difficulty with radiation necrosis, cerebral edema, and management of steroids. So,
Yes.
correct?
Yes.
Yeah, so we do certainly use Avastin for those things. So in my practice, first we of course try steroids. Sometimes we're trying things like Boswellia, high dose hyperbaric oxygen, things like that. But if the patient is requiring high levels of steroids to function, then we start to navigate to some of these other options. So we discussed it at our tumor board. Is there a role for surgery? LITT may be in that pathway if it fits those technical parameters. If there's not a role for those two interventions, or perhaps they've been attempted and the symptoms are still present, then we might consider Avastin, either with that classic radiation necrosis protocol over just a few months, or in addition to some other line of therapy.
I would say actually we've trended away from using Avastin in these cases, in part because the medical oncologist and the radiation oncologist, they want tissue. And so the ablation gives you the opportunity to get tissue and potentially a curative treatment, which the Avastin does not do.
Yeah, that's a good point. So if there's a question, is this recurrence or not, then we're often leaning towards biopsy with laser ablation.
As a follow-up question, then just on the biopsy side, is biopsy a regular step then in the case of progressive metastatic disease, and it's unclear as to what you're dealing with?
Yeah, so yep, a biopsy is definitely a regular step for us in the case of CNS metastatic disease if we don't know if it's treatment-related change or progression. And even if you feel strongly one way or the other, I've certainly been surprised, despite perfusion testing or spectroscopy or all those other modalities that are just unclear, we're often pushing for biopsy. And I do have a slide that I can touch on that with here. So this is a slide describing a study from Journal of Neurosurgery 2019, where if you look at all subjects that had laser ablation after stereotactic radiosurgery, that's this darker line in the middle, patients that had metastatic tumor or radiation necrosis, there's quite a bit of difference in survival and outcome. And it also really puts the medical oncology or neuro-oncology team in a pickle if we don't know if that's recurrence or not, because these patients don't have infinite lines of treatment. Perhaps you you suspect that it's recurrent disease and you switch the treatment that they're on. Now they've lost that option that was maybe an effective treatment, and they're on to something else. Or you're presuming it's a treatment-related change and it's actually recurring disease and you're continuing down a path that just isn't working. So there's certainly data to add value to that biopsy despite that increased risk. So I like having the biopsy, especially. I also think it adds value to knowing what that molecular profile is and how it changes over time. And that body of literature is becoming very interesting and a greater part of our clinical trials. So I guess we still have a fair amount of time, but I'm going to catch through a few of these slides. How does a patient get to a laser ablation as a possible intervention? We talked about our care pathway, and we talked about our tumor board and the different ways that the patients get into that process. But another area I wanted to touch on is how do patients outside of your health system and outside of your immediate geography get to laser ablation? This is an area passionate to me. My personal mission is to improve access to care, whether that's clinical trials, surgical innovation like this, to patients with rare or devastating disease. And so you can see, as all of you know, you can see that there's large areas of the United States and even perhaps the state you live in where there's limited access to high-level or specialized resources. This is a map on the left from a study that we did back in 2016, where each of these dots is either a center that does brain tumor clinical trials or is a high-level cancer center that has the potential to do those studies. So even in our own state of Michigan, there's patients that are driving 9 hours to get to a center that has that specialized care. So part of what I do is I go out in the community and I meet with doctors that are in, the Upper Peninsula of Michigan or several hours away, and I just make sure that those pathways to access our center are wide open so they can get to us. And laser ablation has been really interesting because I've been going and communicating with these doctors, and mostly mostly from a primary brain tumor, spine tumor perspective, like a glioma perspective. But with laser ablation, I'm connecting with a whole different network of doctors. And such a common problem with CNS metastatic disease to have a recurrent lesion after radiosurgery. So I have this brand new network that I'm connecting with, and it's creating new pathways and access points for these patients, which is surprising to me.
Dr. Snyder, maybe a two-part question. First, are you finding that with your LITT patients versus craniotomy patients, that you're more comfortable starting adjuvant therapies more quickly, post-LITT versus craniotomy? That's part one. And then second part, more broadly, where do you see immunotherapies going and LITT likely opening the blood-brain barrier, setting off an immune response? How do you see that developing in the future?
Sure. First question. Yeah. Am I more comfortable starting therapy sooner after a laser ablation than an open resection? Certainly, yeah. Yeah, because I think that the recovery from that procedure is often so much quicker. So that's one concern. And I'm less concerned about compromising that surgical site, which can be a bigger concern, particularly in a lesion that's been previously treated with radiation. I think that starting treatment much quicker is certainly a possibility on a case-by-case basis. Your other question was, what's the relationship, and this is not how you phrase it, of course, but what's the relationship of laser ablation to immunotherapy, and what's the future of that? I think time will tell. Questions about how laser ablation involves the blood-brain barrier and drug access is a perfect question for Dr. Lee, because that's one of his academic interests. So I'd say check out some of his recent publications, because he's definitely moving forward in that direction. But it is really interesting, the idea of disturbing the blood-brain barrier for some period of time and how that impacts the immune system, or how that can affect immune system priming, like to impact other areas in the brain, is always evolving and a hot topic going forward, no doubt.
Super, thank you.
Yeah. Now this slide is about virtual care and how that's impacted our laser ablation practice. So in the bottom right, you can see me on a little computer screen at a brick and mortar facility in mid-Michigan, several hours away from our Detroit hospital that we're in now. And what we recognize is that there's many barriers to care throughout our region. Some of those are technical. So since the pandemic, we've done a ton of video visits from someone's phone or computer in their own house. There's also people that's quite challenging for, and the neuro-oncology community is certainly no exception there. So we have this facility with an advanced practice provider there, and I can chime in via video, as can Dr. Lee, and help them navigate, is there a clinical trial option, or is there an advanced surgical option? And we're only doing that with these very specialized resources. And so when somebody's chiming in through virtual care from 9 hours away, it may not be practical for them to participate in a clinical trial, but it very well may be practical for them to come down, meet with Dr. Lee, do a laser ablation, and head back home with a treatment plan from our tumor board and connect with me via video visits to make sure that everything's lining up well. And the other part of this slide is our referring physician office that goes out and makes sure that those connections are seamless with our external network, so that if you're a physician in another hospital, you can get into our program right away for laser ablation or whatever it is. And I think that's been really helpful to follow through on our mission and connecting patients to this resource. As Dr. Lee pointed out, the NCCN guidelines have recently been adopted to have a stronger recommendation for laser ablation for relapsed brain metastasis, which is perhaps my favorite use case because it's such a vexing problem, radiation necrosis, and recurrent glioblastoma. And those are really the areas that we're pushing the envelope here, maybe expanding glioblastoma to recurrent glioma. A key part of the neuro-oncology job is to monitor our patients, and we usually do that through performance status in the MRI scan. And so it can be challenging when you're starting a laser ablation program to interpret these imaging scans. And this is one of those type of cases. So this is a patient with a oligodendroglioma grade 2 that in follow-up was showing this area of enhancement concerning for high gain transformation just in this focus. The rest of the tumor was largely stable, and it had been years since her initial diagnosis. So the patient underwent laser ablation. You can see this really nice ring around, this is intraoperative MRI, image, you can see that really nice ring around that focus. So you can see where that tissue was disrupted from the laser ablation. But a year later, this is a pre-contrast image, you can see this area of blood products. Actually, this is post-contrast. You can see a little bit of enhancement there too, but you can see this focus of blood products. And even almost 2 years later, we still see this proteinaceous product in that laser ablation address space. So just like you might follow blood products and proteinaceous products after a surgery, we still see that with laser ablation. But to me, if I see that clear ring in shape and it's within that focus and it's not expanding, then I'm usually okay with considering that stable. This is another really interesting case of a 50-plus-year-old man with a left insular T2 hyperintense mass, ended up being an astrocytoma. Patient underwent multiple laser ablations with staged procedure and had a really nice endpoint. This was several laser ablation procedures over a period of time, but essentially has no measurable disease here. Patient elected just to follow with imaging. It's been a few years and we haven't seen recurrence. So we've saved this gentleman what would have probably been radiation and chemotherapy by taking this atypical approach. So how does laser ablation add value to our program? Number one, it improves quality of care in the spectrum of patients that we can serve, and it helps us serve a larger community of other hospitals and other physicians with this population of great unmet need. It's also clearly an evolving technology, and I'm excited to see where the future will take it and how that relationship will be with other therapeutic advances, like you mentioned with immunotherapy, and I'm excited to be part of that discussion and process. I talked about how expanded our referral network, and it's also increased our neurosurgical volume and resulted in a positive financial margin to the system. With that, I'd like to give the mic back to Dr. Lee to present some of his work.
Basically, what we did is we were trying to figure out for the patients with recurrent glioblastoma, going along with the tumor section and the NCCN guidelines. Basically, we took patients with first-time recurrence from glioblastoma with small volume. So we're talking about less than 20 cc's, which I would regard at the upper edge of what you can do with an ablation. So these are patients who would otherwise be open resection candidates, and some of them had surgery, open resection for various reasons, and some of them had LITT, roughly 50-50. And what we're seeing is that in terms of overall survival, they're actually equivalent, with the exception of there was 2 patients who actually underwent supramaximal resections who had greater, had exceptionally long survivals. And I think what this portrays is that if you are dealing with a lesion that is not where you can do like a supramaximal resection, yet you still want to do a cytoreductive procedure for a relatively small volume, if it's ablatable, I would try to ablate it. I think, the longer you do surgery for recurrent glioblastoma, sort of the more nihilistic you get about it. And, knowing that you're not moving the needle that much with a cytoreductive procedure in this setting, we just basically were trying to get them in and out as quickly as we can with the minimum of damage. And I think laser ablation does offer a really attractive treatment for these treatment option for these patients who, 5 years ago, they were all getting open resections. And at the same time, it's, you're minimizing time off treatment, you're getting tissue, potentially in the future, you're giving them more opportunities to get on clinical trials, especially as laser ablation becomes a greater part of treatment protocols. There are several treatment protocols, clinical trial protocols out there now combining laser ablation with adjuvant chemotherapy and immunotherapy. And I think that was our last slide. And Dr. Snyder, I thank you for your attention. Are there any questions from the group?
Well, here's another question that's come in, maybe for the both of you to think about. So have you established a guideline in Henry, any guidelines at Henry Ford for how you think about patients with multiple METs vis-a-vis LITT, SRS, all the treatment options you have in front of you?
Are you talking about like in the newly diagnosed or the recurrent setting? I guess could be either.
Yes, yep, could be either, but they present with multiple METs.
Yeah, I think we still, for newly diagnosed disease, if it's small, we would still generally gravitate more towards radiosurgery. Radiosurgery is very effective for tumors that are less than 2 centimeters. I guess the question is which is somewhat unknown. So where radiosurgery starts to be somewhat less effective, so over 2.5 centimeters, is there a role for a cytoreductive procedure like laser ablation? The caveat to that is that above 2.5 centimeters, that's getting too big for laser ablation too, at least with a single fiber. And so ideally, for those patients with larger metastatic, larger tumors, you would like to offer them some kind of surgery. And if they could fit into that, that would be great. But the difficulty can be is that if it's too big for radiosurgery, it's also too big for LITT.
Would the idea of multiple trajectories, one trajectory per met, but multiple trajectories, would that be a concern or something you and your patients would get comfortable with if you felt it was the right approach?
I think that, if you're dealing with multiple tumors, but they're all small, radiosurgery still works pretty well for that.
Yeah.
If you're dealing with like one dominant tumor that's like much larger, the problem with METs specifically is that they tend to be very spherical, and the laser ablation that you get is cylindrical. And so even with multiple catheter trajectories, you're going to miss some. And at the same time, if you're treating a larger tumor, you might actually set up quite a lot of edema, which our radiation oncologists are really gun shy about those patients, or they can be. And so it's, I showed that one case where I had that patient who had leptomeningeal seeding after an ablation for a larger tumor. And I think, with that experience, we were thinking that if we ablated it, we might improve the effectiveness of radiosurgery. As it turns out, we kind of like, it was a moot point anyway, since the patient had seeding so early after the ablation. She never even she did get radiation, but there was a follow-up scan after that where we saw the seeding. So we don't even know if the radiation helped in that case or the ablation for that matter. Ideally, I think in terms of you want to think not just in terms of diameter, but also think in terms of volume. And then, for a patient with newly diagnosed metastases, they haven't had a prior surgery where they have a resection cavity that you can take advantage of. And so if you're doing ablation that's more than like 15 cubic centimeters, you could really cause a problem with mass effect with those patients.
I'd say we take it on a case-by-case basis, and particularly the complex cases that you're describing, and we try and incorporate these ever-evolving molecular recommendations for brain metastasis into our tumor board. And of course, how responsive different types of lesions may be to other modalities, to whatever treatment it is, whether that's radiation or systemic therapy.
Yeah, I guess I've heard to address a question about blood-brain barrier. I think there's probably a role for that. So the group from WashU, they just published their study was just published looking at laser ablation plus doxorubicin for recurrent glioblastoma, and they did see some survival advantage. Now, it's a difficulty whenever you're dealing with recurrent glioblastoma. Every phase 2 trial looks positive, and then it's when you do the comparison studies that benefit kind of goes away for the phase 3. But I think there is a signal there that doxorubicin in particular is an interesting drug because it is a drug that will penetrate. It's a small molecule. So it is one that you expect would get through this transient blood-brain barrier breakdown. It's a drug that has very excellent in vitro efficacy, but no in vivo efficacy to this point. So, I think that's a really interesting study. And then the studies that are going on right now with immunotherapy, by and large, the immunotherapy trials have been disappointing. But with the combination of laser ablation, potentially, as Jim was saying, like priming the immune system, it might sort of enhance or work synergistically with immunotherapy and enhance the benefit of both.
Excellent. I'll try to squeeze in one last question. Have you guys thought about LITT for low-grade gliomas? I know there's a handful of physicians that are thinking about that. And do you have a view?
Yeah, I think it depends on the case. Like it's, if you're dealing with some of them are very diffuse and ill-defined, like the border is very ill-defined. Those are not great surgical candidates, period, in general. But for those patients who have like relatively discrete margins, although they're not encapsulated, obviously. So these are patients generally, the IDH1 mutant, oligodendrogliomas tend to be better encapsulated. That case that Jim portrayed, that was, that patient, he truly, he was marching to the beat of his own drum. There's always a reason for him not to do adjuvant treatment after surgery. Like one time he was having a baby and he didn't want, or his wife was having a baby, so he didn't want to do chemo. Another time he was doing an IPO, or he was presenting something to venture capitalists, so he didn't want to do anything that was going to lay him up. Essentially, every time I've done actually 2 ablations on him, he found a reason not to have chemo afterwards, or radiation. So, and he was a low-grade tumor. low-grade oligodendral glioma, and knock on wood, he's like 13 some years out now,
Yeah.
and still, outside of
Fantastic.
this anonymous hemianopsia from his initial presentation, he's like living a normal life. It's been a great treatment for him.
Yeah, I'm a big fan of LITT for low-grade
Yeah.
glioma, particularly those patients that have been stable for quite some period of time. There's one area that just seems to be changing.
I think insular tumors, especially insular low grades, it's a really attractive treatment also. Especially for the posterior insula where where the risk of stroke is relatively high. Knock on wood again, we haven't seen any strokes from insular ablations, and we're working on compiling that data now. But it's a really nice cytoreductive procedure for the insula, basically, at least thus far with our first 25 patients or so, basically eliminating the risk of stroke.
Excellent. Well, Dr. Snyder, Dr. Lee, this has been fantastic. Really, really enjoyed it. Generated a lot of interest, as you can tell. So very much appreciate your time, and I hope everyone has a great evening. Thank you all.